Have to ask the patient to go for investigation and which investigation is to be done. Because we get a lot of reference like, that this patient needs ERG. What ERG? When you go through this instruction course, you'll understand all these points. So I request Dr. Vibhuti Bhushan, he'll be talking on Introduction to Visual Electrophysiology. Dr. Vibhuti, please. यहाँ आ गया.
Good morning, everybody. I think, first of all, let me thank the AIOC for giving us this platform, and my sincere thanks to our chief instructor, Dr. B.P. Kashyap sir, for giving me this opportunity to be a part of this instruction course. And this is a very, very important diagnostic tool which is very underrated. It gives a lot of information, but unfortunately, because of the lack of awareness and lack of exposure, we don't use it as much as we should have done it. So I'll be talking about I'll giving you the basic introduction of this electrophysiological tests that are done, so that it makes easier to grasp and to understand the details of the tests which the other co-instructors will be talking about. So we have different procedures to examine the eye, but it is the electrophysiology which gives us the early and specific information about the condition of the eye. And the ISF is the society that standardizes tests. It is used to localize the problem in the visual pathway, because symptoms history and family history clinical examination has its own limitations. Patients with night blindness may have many other causes apart from RP. An absolutely normal looking retina may have no vision, and retinal pigment abnormality may not match the amount of visual loss, the amount of blindness that the patient has. So who are the candidates who should be investigated, who should be put to these tests? The patients with symptoms suggestive of any known neurological or other ophthalmological diseases which require confirmation of the diagnosis, like RP, Best disease, multiple sclerosis, etc. When there is unexplained visual loss, including medical legal problems and defects associated with psychiatric disturbances or mental health, mental and physical handicap. Pediatric neuro-ophthalmic practice, this is a very important tool where media opacities prevent other clinical examinations from establishing a diagnosis, like cataract, corneal opacity, vitreous hemorrhage, etc. And in monitoring the health of retina when the patients are receiving medications which would be retinotoxic or neurotoxic, like HCQ, ethambutol, tamoxifen, and phenothiazines, etc. In detection of the disease or carrier state of inherited visual disorders like RP and cone dystrophy, this is very useful. It provides a quantitative assessment of the progress of an eye disease and in assessment of retinal and optic nerve function following trauma. When we get the referral, if the patients are suspected to have inherited retinal degeneration, then we need to perform a full field ERG, multifocal ERG, pattern ERG. In cases of glaucoma, pattern ERG is useful. In cases of ocular sclerosis, full field ERG. In cases of retinal detachment, full field ERG and VEP. VEP helps in multiple sclerosis. In inflammatory ocular diseases, full field ERG and multifocal ERG is useful. In retinal ischemic conditions like diabetic and avascular disease, retinal full field ERG and multifocal ERG is done. And in endophthalmitis, full field ERG and VEP is done. When there is a failure to read the chart with no other abnormality and visual behavior is normal, full field ERG, multifocal ERG, and pattern ERG and VEP, all these tests are useful. In post-traumatic visual impairment, the pattern ERG and multifocal ERG and VEP. In visual impairment and stress, multifocal ERG, pattern ERG, and VEP is useful. In electrophysiology, basically it records the membrane resting potential and the changes that occurs after the light stimulation. Transmembrane movements of ions in retinal cells, mainly the sodium and potassium. It makes the cells hyperpolarize, that is more negative to the extracellular space than in the dark. In ECG, actually, because the heart beats, so it does not require any outside stimulation. But in ERG, cells are at resting condition and requires light stimulation for the changes to happen at resting potential in the form of hyperpolarization. This is the list of the electrophysiology tests that we do. It is electrooculogram, scotopic ERG, photopic ERG, pattern VEP, flash VEP, and multifocal ERG. Some other tests which are in the experimental stage, like ERG on-off response and S-cone ERG, multi-channel VEP, sweep VEP, and albino VEP, they are also in the pipeline. So in electrooculogram, we get to know about the RPE resting potential. In pattern ERG, it gives us the idea of gross macular function. In scotopic ERG, that is a dark adapted condition, it gives us the information of gross rod function. In photopic ERG, it gives gross cone function. In pattern VEP, the macular ganglion cells. Flash VEP tells us about the visual cortex, and multifocal ERG about the macular photoreceptors. When we have to do a number of tests, then how do we start? We should start with pattern ERG because dilatation is not required for this test, and it is done binocularly. Then we need to dilate the patient and dark adapt for about 30 minutes. Then we do scotopic ERG. Then we light adapt the patient for about 15 minutes and then do photopic ERG. We get a few waves in the ERG reading. The A wave is the negative component which comes from the photoreceptors. The B wave is a positive deflection which is caused by Muller and bipolar cells. And then we have a C wave which is a positive deflection following the B wave, and it comes from the basal portion of the RPE. We get a few oscillatory potentials which are positive wavelets on the ascending limb of the B wave, and they are originated from the amacrine cells. Again here, the A wave is a hyperpolarization of the photoreceptors. The B wave, it reflects the postsynaptic activity of Muller cells and bipolar cells. Then C wave, it comes from RPE, and D wave from bipolar cells, and there are oscillatory potentials from amacrine cells. The full field electroretinogram is a mass electrical response of the retina to photopic stimulations, photoreceptors to the inner plexiform layer. In the pattern electroretinogram, it measures the central retinal and ganglion cell function. Stimulation is done by reversing black and white checkerboard, which alternates and differentiates the optic nerve and macular function. It is recorded using a DTL electrodes, which will be discussed in detail by the next speaker. And P50 macular photoreceptors and N95 ganglion cell layers. The electrooculogram, it checks the change in the electrical potential between the cornea and the ocular fundus, outer retina, and RPE. It is recorded during successive periods of dark and light adaptation. Electrical signal is generated at visual cortex in response to visual stimulation. It assesses the integrity of visual pathway. It reflects the activity of central visual field. The multifocal electroretinogram, it's simultaneous recording of focal retinal responses. It offers direct objective and topographical mapping. It records the central 30 to 40 degree of retinal function. It is a cone-driven response, and fovea, parafovea, and near peripheral photopic retina function can be evaluated. The ERG is recorded by measuring the potential difference between electrodes, one of which may be a contact lens electrode. There is a reference electrodes which are applied close to the eye near the canthus, and there is a ground electrode which is applied to the forehead. This is a very, very important comprehensive chart. On the left side, we have the tests, and then the refractive condition. There are some tests in which we need to give the patient a full refraction, and visual acuity is also important. In some of the tests, like in flash VEP, it's not important. In flash ERG, it's not important, but in multifocal ERG, the visual acuity is very important. Pupil dilatation is again, in some of the tests, it is required, and like in pattern VIP, it is the patient does not need to be dilated. In pattern ERG also, without undilated condition, it can be done. Then test distance also varies. In some of the tests, it is 30 centimeters. In some, it is 1 meter. And fixation is also very important. Like in full field ERG, it is very important. Multifocal ERG, it is very important. And in VEP, it's not important. So with this, I would like to finish my talk, and once again, I thank AIOC and our chief instructor for this opportunity. Thank you very much.
Thank you, Dr. Vibhuti. A very good presentation and overall view of the ERG. May I request Dr. Rahul Prasad to proceed with his knowing the machine and the electrodes. We use this machine with, which has a lot of different aspects and how to test it. People think that ERG is something else and multifocal ERG is something else. So he'll be telling us about the details, the electrodes and the machine. Dr. Rahul, please.
Thank you, sir. And at the onset, I would like to thank the All India Scientific Committee and the Chief Instructor for giving me the opportunity to present a very interesting part of ERG. Just now, Dr. Vibhuti sir explained about the basics of the ERG and why it is required in our retinal diagnostics. My job is to let you understand what are the requirements for doing an ERG. So basically, the machines and the electrodes. So to record an ERG, two things have to be understood: the basic technology and the clinical protocol associated with it. The basic technology includes electrodes, stimulation of light, and the electronic recording device. The clinical protocol understands the preparation of the patient, the ASCEF standard ERG, and the analysis and the reporting of the ERG. Now, coming to the first part, those are the electrodes. Basically, there are three types of electrode required for recording ERG. They are the active electrode, reference electrode, and the ground electrodes. The electrode stability is maintained by a very good connection as it decreases impedance, and more impedance would mean more noise, and that would lead to wrong reading. Electrodes need to be kept clean to avoid infection and also for its reusability. It's also important to note that cleanliness decreases the impedance. For a good recording by an active electrode, one has to ensure the use of non-irritating, non-allergic, ionic, conductive, and a relatively non-viscous solution, a good ocular contact to ensure proper electrode impedance, and we should define both the normal values and variability for our own laboratory. Now, active electrodes basically can be of conductive fibers, foils, conjunctival loop electrodes, and contact lens electrodes. These contact lens electrodes are centrally transparent with an optical opening, just works like a lid speculum, gives the best recording, and the recording is stable even with higher amplitude. Now, the different types of electrodes are skin electrodes, which are mainly used in children, corneal ERG electrode, monopolar, those are jet contact lens electrode, and the bipolar, that was the Burian electrodes. Then we have got the DTL electrodes. This is one of the most commonly used electrodes in the ERG. Finally, the gold foil electrodes. We'll be discussing this at our later stage. Then, after active electrode, we have got reference electrode. They are incorporated into the contact lens speculum assembly when one uses bipolar electrode like Burian or electrodes for stable configuration electrically. Now, electrodes can be placed near orbital rim or earlobe or forehead. The third type of electrodes are the ground electrodes, where a separate skin electrode is attached to an indifferent point and connected to the ground. The typical location for placement of the ground electrodes are forehead or ears. Now, what is actual electrical impulse that the ERG calculates? Now, it is the impulse that is captured by the active electrode, which has got two things. First is the potential changes and the impedance, and the reference electrode, which captures the impedance only. Now, subtracting this, that is E minus R, actually gives us the actual electrical impulse. Now, coming to the individual electrodes, the first is the jet electrodes. These are disposable monopolar contact lens electrodes, gold foil electrodes, or polymethacrate with lead wire. Ease of insertion is there. Movement of lens during recording in absence of lid speculum contribute to its variability of the recording. It reduced possibility of eye infection, but the only disadvantage is the gold plating itches off with time. Then the other commonly used electrodes are the Burian-Allen electrodes. These are bipolar reusable contact lens electrode with built-in lead speculum with a lead wire. They are customizable to various sizes, ideal for infants. The reference electrodes are built into the electrodes, which are conducting coating of silver granules. PMA shows variable degree of blurring, so not suitable for recording pattern ERG where the image clarity is vital. They are generally used in full-field ERG, but the only drawback is it's very costly. Then the DTL plus are the microconductive thread electrodes. These are the most commonly used electrodes. They are conductive threads 50 microns and float on the corneal film surface. It has a negligible mass, low cost, and disposable. It's convenient to use and gives a very clear image. No interference with pupil or optics, as we can see in the picture. It gives a very reliable ERG reading, and they are well tolerated by children. Then we have got the gold foil electrodes. They are useful when you cannot use a contact lens electrode or when you don't want to anesthetize the cornea. The ERG amplitude will be substantially affected by this electrode, and it requires an adapter. So the color coding for different electrodes include the active electrodes are red in color, the reference electrodes are blue in color, and the ground electrodes are black in color. In the preparation side, the skin has to be cleaned properly for the reference and the ground electrode, and for that purpose, we can use skin prep gels as a new prep gel. Now, cup of the electrodes are filled with gel and are attached for better conductivity. These are the channel which connects the active reference and the ground electrode. There are two types of channel. There are channel 1 and channel 2. Now, test for one channel, then we use one eye, then we use a one channel, and if we are testing for two eyes, we usually have got the two channel adapters. Then comes the second part. Those are the machine. Now, what are the different machines different part of the machine that we use for recording ERG? We have got a computer monitor, which tells us at what stage the investigations are going to go on. And then we have got the part where the stimulation actually is seen by the patient. Now, this then again has got two kind of monitors. One which gives us a pattern stimulation, and a Ganzenfeld valve which gives us a flash stimulation. Now, this is a side view to show how the electrodes are placed. Now, in a multifocal ERG, one eye is closed, and this is how we keep the electrode and patch the eye. There is a movable chin rest which has to be placed in front of the monitor. This is a picture which demonstrates the ERG getting along, where the chin rest with monitor and the fixation point can be seen. The monitor displays the random pattern of multifocal ERG. Then, after that, completion of the test, the chin rest is removed and the Ganzenfeld ball is comes into the action. Now, this is a closer view of baby flash for babies and unconscious patient. This is what Ganzenfeld ball gives a closer view. The movable child rest has attached in the other place when the test is finished. This is a picture that shows different electrodes put in the different places in the different tests. So recording the ERG, the test procedure is explained to the patient. Pupils are fully dilated, size of the pupil are recorded. The patient is dark adapted in a dark room with an eye patch, electrode attached with a dim light in the room, and we start the test. Attach the electrode and follow the guidance coming on the computer screen. Now, there are some safety informations that have to be kept in mind, such as the printer and the external USB hard drive should be connected via Wi-Fi, and if disconnected, should not be tried to connect while the test is being performed. The automatic windows of the system should be deactivated. The dark room should be kept properly dark. Disconnect the power supply before any cleaning or repair, and there should not be use of an extension cord. To use an external, it's always good to use an external drive to have a regular backup, and a password should always be used to protect the patient's data. For the patients, electrodes should never be used in the damaged skin. The patient should be thoroughly explained about the procedure, and all the doubts have to be cleared, and the waste should be disposed in the household waste. Thank you very much, sir.
Thank you, Dr. Rahul. We really appreciate your presentation because it really explains us the different kind of machines. So you talked about the Gainesville bowl, where you get the flash stimulation. The other is screen, where you get the stimulation by the screen, and flashlight for the babies. Very nice. So do we have any question? If not, then we proceed to the next presentation. I'll be talking about the full ERG and the multifocal ERG. Good morning again. So I'll be talking about full field ERG and multifocal ERG. So first of all, let's talk about the full field ERG. Now you have to take precaution while doing any ERG. That is, there should not be light thrown in the patient's eye, because you have to make the patient dark adapted. So if you have to make the patient dark adapted, please do not do indirect ophthalmoscopy or FF or any test. Otherwise, if you have not put the light in the eye, you have to do the dark adaptation for 30 minutes. If you have put any light like indirect ophthalmoscope, then you have to make the patient to dark adapted an hour or so. So the electrodes for the full field ERG is like Dr. Rahul said, that it will be a reference and ground, and the electrodes are like this. In both the canthi and the forehead is the ground electrodes. So the tests are scotopic, that is in the dark condition. In dark condition, when you throw a very small amount of light. Imagine the full field ERG is always a flash of light. So very small, very dim light is thrown. So dim light to 0.01, then you get an isolated rod system function and dysfunction and response. If a little on the stronger side, let's say 3 ERG, you get a response from the rods and cones. And if it's 10 ERG, you get a combined response of both, little stronger. And if it is at 3, it means we get a response from the hemacrine cells also, which is like a oscillative potential. And in photopic conditions, we make the patient to get the light adapted for 10 minutes and do these tests. We throw a flashlight, and we get a cone response. And you get a flickering of lights. In that, what we do is we reduce the amount of rod response. We only get the cone response only. So if you give a very small light, you don't get any wave, but there is still a positive wave. People always ask, what is this wave? So there is an arresting potential that there is some activity going on. That's why you get this kind of a response. Basically, a very, very small amount of light that is given, and flashes are of 2 seconds interval. And the response that you give is rod, and it tells about the dysfunction of that rod cells. If you give a little bit more light intensity, and the interval of flash through is 10 seconds. Then you visualize the A wave and plus B wave also. So this is a combined wave, combined response. Little harder, little stronger, that is, you give a 10 cannula and the interval should be 10 seconds. Then you get a A wave and B wave with oscillatory potentials. Oscillatory potentials, if you want to see only oscillatory potential, that is from the bipolar cells, occurring bipolar cells, then the interval has to be 15 seconds. And in light adapted, that is single flash, one response, and you get a wave, that is photoreceptor rods, and B wave, that is a bipolar cells. So in a flicker, that is 30 hertz flicker, you get a 30 stimuli per second. It suppresses the rod. But if you're taking this response, you have to discard the initial few seconds recording. So why I'm saying this? Suppose if you have a suspicion of rod dysfunction, you have to stimulate accordingly. Cone dysfunction, you have to stimulate accordingly. If you are only looking for if there is any problem in the cone or not, you do the test accordingly. So these are the responses that you get from different tests. So A wave, like Dr. Rahul said, that is a negative wave, originates from the photoreceptor. B wave is a positive wave, arises from the Muller cells and bipolar cells. And to get any kind of response that full field is defective, at least 20% is necessary for the ERG changes. So 20% should have been damaged. So look at this diagram, this is very important. In the periphery, what happens is there are a lot of photoreceptors. These photoreceptors come to little less bipolar cells, and then they come and join little less amount of ganglion cells. Unlike macular area, where you have a bipolar cells, we have a photoreceptor cells, and almost same amount goes to the same amount of bipolar cells and then same amount of ganglion cells. So the central part is quite dense in photoreceptors, dense in bipolar cells and ganglion cells as well. But then you'll have to differentiate. So if you want to take the central thing, you go for a pattern ERG, or you can go for the multifocal ERG and part of the full field ERG. So these are the normal responses of full field ERG. Suppose this is normal, and suppose if you have some problem like CRVO. So in CRVO, the rods are functioning well. So we'll get a response of minus the negative A wave, but you don't get a good response of the bipolar cells and bipolar cells. So you have got a dysfunction of the cone. So even in the oscillator potential and the 30 hertz flicker, you have a less response. If there is a cone dystrophy, what do you expect? You expect that the A wave should be normal, and there is no response of the bipolar cells. There is no response of the amacrine cells. So you get a flat ERG. The negative ERGs nowadays is considered very important. The B wave has not even reached the hemorrhage. You will not know after the clearing the vitreous hemorrhage whether the patient will get the full good vision or not. So these are the tests that are very important for this. And especially nowadays, a lot of people are going for hydrochloroquine and chloroquine for different diseases, even arthritis people are taking, and the patient says that he is not seeing anything. So you have to go for a full field ERG and multifocal ERG. In multifocal ERG is a relatively newer thing, and it basically takes care of the central position, that is 0 degree to 36 to 40 degree, almost goes to near mid-periphery. And it is basically the cone-driven response, and it tells you the health of the fovea center, parafovea, and near peripheral photopic retina. So what is the difference between the full field ERG and multifocal ERG? In full field ERG, you have to have a bowl, and flash of light comes from the bowl. And multifocal ERG, there's a screen. The checkers board are there, it keeps on flickering. And then recovery, when you see the response, you see the waves in the fulfilled ERG, but in multifocal ERG you get a topographic representation. And these, the checkers board can be from 61 to 103 hexagonal arrays, and it is not the individual wave you see. It is a total summation, mathematical summations, and it tells you that ultimately what is the function of the ERG of the retina. So for multifocal ERG, this is the way you go for electrodes, and it provides a high resolution spatial and temporal information from the retina. Frame changes are for every 13.3 milliseconds, that comes to approximately 75 hertz, and the CRT monitor device to deliver the multifocal stimulation. So this is the type of stimulation that we get. The patient fixates in the center, and this flicking goes on, and ultimately all these electrodes, they take over, they take all the responses and calculate and give you the picture of the topographic picture of the multifocal ERG. So if you are doing a multifocal ERG, the pupil has to be dilated, and the distance from the screen should be 33 centimeters. And fixation point is very important because you are seeing the function of the macula, the fovea has to function well, so it is very essential. And you have to correct the full refraction. It should be dark adapted, and room light can be normal, and duration of the recordings approximately 60 minutes. So you have a different rings. So most of the drugs which affects, and then it has a toxicity, you have to go between the second and third ring. So all these rings represent different part of the fovea. And in Stargardt disease, the central portion is gone, so you have got a dark depression. So to see the function and to see the result of the multifocal, it looks fantastic and is very easy to diagnose, and is very, very convenient even to explain to the patient. And as I told you, it's all the summations of these waves. There's a difference between the multifocal ERG and pattern ERG. The multifocal ERG basically consists of function of the macula, and pattern ERG is basically the macular ganglion cells. Dr. Vibhuti Kashyap will be talking about it in the detail. And we do it for macular dystrophies, central serous retinopathy, drug toxicity, inflammatory conditions. Dr. Vibhuti has already talked about all these. So in case where you want to fixate the eye, when the fixation is important, in that case, the pupil should not be dilated, the refraction should be done properly, and the patient should have good vision. If the patient does not have a good vision, instead of go for the VEP. Dr. Didi will be talking about all this. So Dr. Vibhuti Bhushan has talked about all investigations to be done in which cases, and the diseases that is required these investigations. So beautiful topographic representation of multifocal ERG makes it very easy to understand and give consent and give advice to the patient. Thank you very much. May I request Dr. Vibhuti to please talk on pattern ERG? And now since there have been talk on central retina, so it becomes all the more important about the pattern ERG. People are talking about pattern ERG even in cases of glaucoma. This is very, very important. So at the sake of even repetition, please go ahead, Vibhuti, and give your talk.
रिव्यू रूम में अपलोड किया हुआ है विभूति कश्यप आज हाँ हाँ प्रतिनिधि मैम आपका
patient is after 4 months. Yeah. The patient will remain asymptomatic. What you see a definite change in OCT. There will be ellipsoid cavity there.
Everyone, and I would first like to thank AIOC for accepting this instruction course, and thank you Dr. B.P. Kashyap for making me a part of this. My today's topic would be pattern ERG. So, what are the retinal disorders that are most likely to be mistaken for an optic nerve disease? They include CSR, posterior scleritis, Azor-old CRAO, cone dystrophy, autoimmune retinopathy, etc. So what happens when there is a poorly functioning retina, a poor visual acuity, and we are not able to find anything on the posterior pole? We usually tend to order a VER. That is the first go-to electrophysiology, the most common electrophysiology that is performed. But what happens is that if there is a disorder at the macula or the optic nerve, a VER will give equally reduced results. So this, if you have to take home anything from my presentation, it is the two graphs that I'll be showing you right away. So in this graph, what we see is that the shaded bar represents a maculopathy and a dotted bar represents an optic nerve dysfunction. So what we notice is that below the upper limit of normal P100, both maculopathy or optic nerve dysfunction will have reduced VEP. But if we extrapolate VEP values against the P50 values of a pattern ERG, we will realize that the P50 values will remain normal for an optic nerve dysfunction, but for a macular dysfunction, a VEP will be abnormal along with a P50 wave. So basically, what pattern ERG does is that it enables an optimal pattern VEP interpretation. I'll explain this further with this example. So this was a 12-year-old boy presenting with left eye diminished vision of 6/18. Right eye was normal. And the posterior pole was unremarkable. So as is the practice, the patient was ordered for a VER, and the VER came diminished. The P100 wave was reduced. So a diagnosis of an optic nerve dysfunction was made. But because there was no history of any insult to the optic nerve and there was no other abnormality, the baby was further subjected to a pattern ERG, and what we found out was that the P50 wave was reduced and the N95 wave was relatively normal. That is, it came out to be a macular dysfunction with a reduced VEP, which was diagnosed as an optic nerve dysfunction when only VEP was done, which cleared out to be a macular dysfunction after we corroborated it with a pattern ERG, and that is what the use of pattern ERG is. So pattern ERG basically assesses the central retinal response to a structured non-luminance stimulus in a temporally alternating pattern. It provides useful information in the distinction between the macula and the optic nerve dysfunction. In this, the net retinal illumination remains constant and only a redistribution of the pattern of light and dark area is made, which is called isoluminant pattern reversal. Comprises mainly of two waves, P50 and N95. P50 is driven by the photoreceptors of the macula, and N95 comes from the optic nerve, the ganglion cells. A good way to remember is that N stands for nerve and P stands for photoreceptors. So P50 is for macula and N95 is for the optic nerve. So of course in macular dysfunction the P50 reduces or the latency increases, and optic nerve dysfunction N95 reduces or the latency increases. Two types of pattern ERG, transient and steady state. What we use for our interpretation is the transient state pattern ERG. Requirements have already been discussed. I'll just brush through the positioning at 100 centimeters, lighted adequate patients, non-dilated pupil, fixation is important, excessive blinking needs to be avoided, optically corrected. This is the stimulus, a black and white reversing checkerboard with a mean width and height being 15 degrees and 0.8 degrees respectively. This is the fixation board with a cross at the center, the red cross that needs to be fixated. The mean luminance need to be constant during checkerboard reversal as it is isoluminant. High contrast, brightness at least greater than 80 CD per meter square. Reversal rate of 4 Fs per second, frame rate of more than 75 Hertz. It allows for a uniocular or a binocular recording. Electrodes have already been discussed. We usually use a DTL or a gold electrode. The placement of the electrode has also been discussed. So what is important, I will lay stress on this point, is that we have to use the skin prep gel and the conductive paste because the impedance recording during the recording of the waves is very, very important. I'll show it in the further slides. So this is the instruction manual in the machine book. So how do we go about recording it? So when we first open the machine, we select for the patient and we select for the modality, select for the patient again, and this is the screen that opens up. So what we do is, you see at the bottom right, you have a column of impedance. We click on that and we see if the impedance in the electrodes are okay. All of it has to be less than 5 kilo ohms. This is very important, and this is exactly why we prepare the skin with the gel and the conductive paste, so that the impedance comes within normal limits, else the recording will be flawed. How? I'll show it in the next slides. So once the reference and the active electrodes impedance is checked, we again apply the pastes and reapply the electrodes till we get all 4 columns green. Once we do get the columns green, we click on the analyze button, and after recording, this is what the picture shows. This does not look anything close to a normal P50 and an N95 wave that we see, because the the scale is very high. The scale is 50 microvolts, but the recording is very, very low. So when we have to reduce the scale of the bar graph, when we reduce the scale of the bar graph to 5 microvolts per division, that is where we get a proper formation of a P50 and N95 wave. What we see in the left eye, in the right eye, is that the P50 and N95 wave is still not properly formed. So what we see when we go back to checking the impedance, we see that the active electrode's impedance was not right. So we have to again correct and recorrect and correct it again to have a correct reading. This impedance is very, very important. This is the technical details of the recording equipment, which is not very important practically for us. How does the reporting show? It measures the P50 and N95 amplitudes, the latencies, the stimulus parameters, normal values, and representative values. This is how the report of the pattern ERG looks like. Now, where do we get abnormal P50 amplitudes? P50 means macula. So macular edema, CSR, Stargardt's, early central retinal abnormalities, and abnormal N95 amplitudes in ganglion cell dysfunctions or any optic atrophy or dystrophy, glaucoma cases, optic neuritis, etc. So as we all know, pattern ERG is an adjunct test. It has to be supplemented with ERG or in certain cases EOG and VEP. Pattern ERG is also detectable in no PLIs, and it helps distinguish central macular dysfunction from peripheral macular dysfunction. If we record the central 15 degrees and the P50 comes abnormal, and we expand the degree coverage to 30 degree and we have a normal recording, this implies it is a paracentral macular dysfunction, not an exactly central macular dysfunction. So kind of sort of roughly a multifocal ERG's role this pattern ERG can also play. Now, what are the other uses? One of the very common and very commonly applied use in our private practice is early glaucoma detection and ocular hypertension, especially in patients having either a positive family history or other parameters of ocular hypertension being present, like CCT less than 555, age more than 40, and having a family history positive. Apart from that, monitoring drug toxicity in cases of patients taking neurotoxic medications like chloroquine, etc., and monitoring therapeutic success after we instill steroids for either optic nerve dysfunction or followed by anti-VEGF injections for a macular edema case. Thank you. That's all for pattern EIG.
Thank you, Dr. Vibhuti. Thank you very much. It was quite elaborate, and You made the things very easy because people are, confused what to order in case of a central field, that is whether it's macula, the multifocal ERG or pattern ERG or full field ERG. So it was a very nice presentation. Our next presentation is by Dr. Bharti Kashyap. She'll be giving tips on EOG.
So first of all, good morning everyone, and I am thankful to All India Ophthalmological Society and our Chief Instructor, Dr. Kashyap sir, for giving us this opportunity. So I will be talking about EOG, and this time I have added few more clinical examples in my presentation. Hope it will be beneficial to all. So there are tips on electrooculogram. Who is credited with the first description of EOG? The EOG is described and named by Elvin Marg in 1951. The clinical applications were described first by Geoffrey Arden. EOG is the test to measure standing potential of the eye, approximately 5 millivolt, indirectly transepithelial potential that exists between the cornea and the Bruch's membrane at the back of the eye. The normal light peak requires normal functioning photoreceptors in contact with the normal functioning RPE. It tests RPE and outer retina. Actually, before the clinical examples, I am giving some anatomy and physiology behind this and the principle behind this EOG, so that it will be easy to understand. During the 15 minutes period of dark adaptation, there is a fall in the recorded standing potential, typically reaching a minimum at 10 minutes, and this is referred as the dark trough. Following light onset, there is an increase in the transepithelial potential of the RP, producing light rise of the EOG. The light rise is ultimately the result in intracellular free calcium, which is released from the endoplasmic reticulum, regulated by an interaction between endoplasmic bestrophin and L-type calcium channels associated with the basolateral membrane. The intracellular calcium gates the opening of the basolateral calcium-dependent chloride channel, and increased chloride conductance depolarizes the basolateral membrane, which increases the transepithelial potential, recorded at increase in the standing potential of the eye. The prerequisites are dilated pupil, full extraocular muscle motility, refraction correction is not needed, pre-test 20 minutes room temperature, light adaptation, good visual acuity, and impedance should be less than 5 kilo ohm. The instructions are: head position should be stable, eye movement only in horizontal direction, head should not move, never anticipate and move prior, increase illumination in case of non-dilating pupil, avoid any bright light procedure before EOG. The Ganchfield dome is the stimulator. The fixation target is 2 LED lights, 15 degree left and right of the central light. And the it is bright during light adaptation and minimal brightness in the dark. The pupil should be dilated before testing, and after suitable skin preparation, the recording electrode should be placed close to the canthi of the each eye. For the dark phase, total darkness should be maintained for 15 minutes except for the dim fixation light. And for the light phase, a Ganchfield background light of 100 photopic candela per square meter should be turned on. Continue the recording for 10 seconds out of every minute in each phase. Active and reference. The position of electrodes near medial canthi is very important. It should not touch. There should be separation, else there will be a contamination which can go up to 40%, and it should be less than 15% contamination. You can see here on the picture there is a black ground electrode, blue reference electrode, and red active electrode. In our hospital we use this, and the patient has to move his eyes to LED with single sweep with head fixed. Circuit recorded 10 to 15 seconds per minute, 40-50 seconds rest. Measure 15 minutes in dark and 15 minutes in the light. Arden ratio. Now I am discussing the clinical part, how it is applied clinically. So Arden ratio is very important. It is light peak by dark trough. It is normally 2.1. Less than 1.7 is abnormal, and usually it is seen in the Best disease. The parameter which should be included in EOG report is light peak and dark trough ratio, dark trough amplitude in microvolt, implicit time from the start of the light phase to the light peak. Also mention type of adapting light source, pupil size. Note any difficulties encountered during testing which may affect the confidence in the results, such as inconsistent eye movements, etc. What is the reliable EOG? The reliable EOG is presence of square and regularly placed waveforms. If it is not proper, that means patient is either not fixing properly or electrode is moving. Light and dark values taken in respective adaptation period, typically 12 minutes for dark trough, and 20 to 25 to 26 minutes for light peak. Background illumination, again you have to check 100 candela. Normal light rise is in EOG requires a normal RPE and good photoreceptor function. As the light rise depends on the photoreceptor function also, patients with abnormal rod function will have a corresponding reduction in the light rise, thus mirroring the extent of the rod photoreceptor damage also. So, if ERG is absolutely negative, then EOG would be absolutely negative too. Some photoreceptor action is must to have an EOG reading, so we recommend always to do ERG and EOG together and never in singular form. A bit in case of good rod function in ERG, a reduction in the light rise in EOG is suggestive of abnormality located in RPE, that is Best disease. Now few clinical tips. The most common diagnostic use of EOG is to confirm vitelliform macular dystrophy. Patients with Best disease and some patients with adult vitelliform dystrophy have normal ERG and abnormal EOG. You can see here the EOG is reduced. Now, the electrophysiology in bestrophin gene mutated dystrophies, in Best disease, which is autosomal dominant, and other kind of bestrophin gene mutated dystrophies, EOG is reduced and ERG is severely reduced in only ADVIRC. ADVIRC is autosomal dominant vitreoretinopathy. Usually ERG is normal, and in autosomal recessive bestrophinopathy, it is moderately reduced also. I will show few clinical examples. EOG is abnormal irrespective of the stage of the Best vitelliform disease. You can see here in one case it is a vitelliform disease, and another case fundus is looking normal, but in both the cases the EOG is showing abnormal. Here, if a child with suspected Best disease is, suppose you cannot perform EOG, then you test both the parents, because one carrier parent will surely exhibit abnormal EOG. This is one case of Best disease, autosomal dominant, 11-year-old male, blood vision, BCVA 6/9. You can see the fundus picture, you can see the vitelliform disease, and you can see in autofluorescence. But if you cannot see vitelliform lesion, fundus looks normal, then also this autofluorescence, fundus autofluorescence helps, and this region in autofluorescence will be there in case of there is abnormal looking fundus. Absence of abnormal looking fundus. Here in OCT you can see the SRF, subretinal fluid, and vitelliform deposits. So here you don't have to give intravitreal injections, but if CNVM develops, then in that case you have to give intravitreal injection. Here you can see ERG is normal and EOG is reduced. The light peak in the bright field is reduced. This is another case, 10-year-old man, male, born out of consanguineous marriage, blood vision, BCVA 6/18 partial, hypermetropic diffraction, and narrow angle. You can see by fundus photograph there is a lipofuscin deposits, and in fundus fluorescein angiography there is it is not very clear. The diagnosis is not very clear. But once you go to the fundus autofluorescence affair, you will see subretinal fluorescein deposits predominantly outside the macula. And here it is not diagnostic, here it is diagnostic. And here you see that OCT. In OCT, it is the accumulation of fluid within and beneath the neurosensory retina. Here you see ERG. This is autosomal recessive bestrophinopathy, and you can see here ERG is abnormal, here EOG is totally extinguished because it is inherited autosomal recessive way. So in this case both ERG and EOG reduced. In this case this is autosomal dominant Best disease, ERG is normal, EOG is diminished. This is the autosomal recessive ARB. In 2017, the newly devised International Society for Clinical Electrophysiology ISF standards for clinical EOG induce fast oscillation of EOG. This is actually not very much in practice, but we should know that in near future it will be more popular. The advantage of FO EOG is test time is shorter, making it easier for patients to be tested. Slow oscillation of the EOG are recorded during 15 minutes of dark adaptation, following by 15 minutes. On the other hand, FO EOG has the advantage of greater compliance because the total inspection time is 15 minutes. The fast oscillations are different from typical EOG, which is dependent on calcium gated chloride channel. These are sinusoidal in form, different from the typical square form of EOG. The alteration takes place in 1 minute interval, and mechanism is also very different. This happens at the apex of the RPE, near the retina, not at the base. The fall in subretinal potassium reduces the movement of chloride ions into the RPE. This is not calcium dependent. The resulting hyperpolarization is responsible for the light trough. There it was a light peak. Here it is a light trough followed by dark peak. There it was a dark trough during recovery. Here apex is having different potential. It has a role in distinguishing whether CSC is central serous retinopathy is acute or chronic, evaluating RPE function. In chronic CSC, decreasing RPE function is confirmed by decrease in amplitude of light trough of FOEOG. FO parameters can be used as indicators for detecting the severity of macular function disturbance and predicting the visual outcome for this in CR view also. So thank you so much. So I discussed in detail anatomy, physiology, and the applied and the clinical.
Thank you, Dr. Bharti. Quite elaborate and newer aspect of the EOG also. Thank you very much. Our last speaker is Dr. Nidhi. So she'll be talking about the VEP. The ERG part of the VEP, the VEP part of the ERG is most looked for. People say whatever, if any ERG, okay, the VEP. So in VP, we can find VP in so many places, especially all the neurologists that do VP very regularly. So she'll be talking about the VEP in a little elaborate way to make us understand. Please go ahead, Dr. Nidhi.
Good morning, everyone. Thank you, sir, for accepting me in your IC. I would be talking about visual evoked potentials. I have no financial interest. Now, electrical signals are generated at the visual cortex in response to visual stimulation. These occipital responses correspond to the central visual field, and they assess the intracranial visual pathways and their functional integrity, ranging right from the retina to the optic nerves to the optic chiasma, optic radiations, and the occipital cortex. The peripheral retinal projections are within the calcarine fissure, but the central retinal projections are in the occipital lobe. The foveal projection is magnified at the cortex. So the linear extent of the cortex in millimeter is very high, corresponding to the fovea. It is 5.6 millimeter per degree, and 10 degrees away from the fovea, it is only 1.5 millimeter per degree. So the indications for which VP can be used is optic neuritis, multiple sclerosis, optic atrophy, hereditary optic neuropathies, toxic neuropathies, traumatic brain injury, compressive optic neuropathies, glaucoma, amblyopia, and also for unexplained visual loss, malingering, pre-surgical evaluation, and measuring the visual acuity in non-responsive subjects. So the requirements here, we will have an active reference and ground electrode. The impedance should be less than 5 kilo ohms, and between the active and the reference electrode, the impedance difference should be less than 20% always. Now the placement of the electrodes follows the 2010 rule, in which the whole head is divided into multiple divisions, and we have the reference electrode, which is placed at FZ position. We have the ground electrode placed at the top of the head, and the active electrode placed at the OZ position. So this is how the machine will look once we connect the electrodes, and here we need to check that all electrodes have the impedance of less than 5 kilo ohms. Now the stimulus used for VP can be a flash, pattern, color, or motion. For the flash VP, the Gansfield stimulator is used, and for pattern VP, we have the CRT monitor. Now, this is all according to the ICF standards. If we look at pattern VP, that is the most commonly done VP, done in patients who have good visual acuity. Patient should be light adapted, sitting at 1 meter with correction and undilated, and it should be done monoocularly. Flash VP is done for patients who have poor visual acuity. Here also the patient would be light adapted. The room will be dimly illuminated and done monoocularly. In pattern VP, we have a checkerboard pattern in which the pattern is reversed. We have different check sizes and a constant luminance and high contrast. In flash VP, we need the field size to be more than 20 degrees and at least one flash per second, that is a frequency of 1 hertz, and a low intensity and high flash intensity and background intensity. In pattern onset and offset VEP, the stimulus is similar to the pattern VEP, but here the pattern is flashed on and then off. So pattern VEP most commonly used, investigation of optic neuropathy. Additionally, flash would be used when the optics are poor, cooperation is poor, or vision is poor, or when pattern reversal cannot be done. Pattern onset and offset is done in cases having nystagmus or malingering or amblyopia. So in pattern VEP, this is the checkerboard stimulus. The pattern is reversed, black to white and white to black. Here we need to avoid the artifacts like blinking of eye, the lesser the better. The total number of tests that are done per individual test should be at least 64, and this test is repeated at least twice. In cases of infants or uncooperative patients, the numbers per test can be reduced. So checks which are subtending in 15 minutes of arc are the best stimulus for testing foveal vision, and 60 minutes are superior in evaluating parafoveal function. Therefore, using more than one check size will increase the diagnostic yield. If the resulting VP using the 60-minute check is poorly performed, then retest using a larger check size or use a pattern onset stimulus. So this is how the waveform will look for pattern VP. We have a negative, positive wave. So the first negative is N75. Here the most important one is the first positive, which is the P100. The latency needs to be seen here. That ranges from 90 to 110 milliseconds, but then it can also vary from lab to lab. On an average, 100 is taken as normal, and the P100 amplitude should normally be more than 5 microvolts. So this is how the output will look. Criteria for abnormality, the latency criteria is prolongation of more than 3 standard deviation, or interocular latency of P100 is more than 10 milliseconds. In cases of amplitude, we need to see that interocular amplitude ratio is not more than 2:1. If the amplitude is abnormally low or high, and absence of identifiable VP from the midline and lateral occipital sides. So this is how a normal waveform will look for the right eye and the left eye. In cases of traumatic optic neuropathy, here you would see that the right eye is normal and the left eye has the neuropathy, and there is a delayed implicit time as well as the reduced amplitude versus the right eye. In cases of AION, here again the implicit time might be normal, but the amplitude is reduced and the waveform would appear a little wider. Papillitis, again delayed implicit time and moderately reduced amplitude in the right eye versus the left eye. This is a case of patient having optic atrophy with left eye having no PL. The left eye, no signal is elicited versus the right eye, which was normal. So VEP can also be used to evaluate the prognosis and the progression of cases having optic nerve gliomas and neurofibromatosis. So over the time, if you see that the P100 latency might actually increase, and thus there is compression due to the optic nerve glioma. This is a case having ethambutol toxicity, and the P100 shows less peak times. This is a case of patient having meningeal tuberculosis where there was again prolonged P100. Coming to pattern onset and offset VP, pattern is flashed on and then off. So 200 milliseconds it is on, followed by 400 milliseconds of off equiluminant diffuse background. The check site again is 60 minutes for large and 15 minutes for smaller. Pattern onset or pattern flash stimuli produces a more robust VP than does pattern reversal in the central 30 degrees. So this is the difference. In case of pattern onset and offset, we have it on, and then for twice the amount, it is a diffuse equiluminant background. And in pattern reversal, the white-black checks are reversed. So pattern reversal stimuli usually exacerbate nystagmus and interfere with the ability of the eye to maintain foveal fixation. Thus, detection of visual acuity is good with this in cases of nystagmus. It is also less sensitive to poor fixation, eye movement, and deliberate defocusing. Thus, it is useful in examining patients that might be malingering, and it has the most productive stimulus for monitoring amblyopia. So this is the waveform here. The C2 is most important, whose latency is normally 100 to 120 milliseconds. Flash VP, again, for uncooperative, unconscious patients having media opacities, to prognosticate eyes with poor vision before planning surgery, and to monitor visual function of babies. So VP is often prognostic in delaying maturation of the visual system. So usually the infant with delayed maturation has a normal flash VP, but permanently cortical blind infants will have abnormal VP. So this is how the waveform and output will look. Here we can adjust the peak and troughs of the waveform to get more prominent waves. So here also we have multiple negative and positive waves. The most important here is the P2 and N2. So P2 latency is normally 100 to 120 milliseconds, and the N2 P2 amplitude normally should be more than 10 microvolt. So this is how the output will look. What we need to see majorly is the N2 P2 and the P2. Just a note on sweep VP done for infants, suspected malingers or disabled subjects. Here the visual acuity is actually extrapolated and calculated in logmar units. So this is how the result interface will look, and everything is extrapolated here through an algorithm. Multifocal VP is a little more advanced. It is an objective assessment of visual field like a perimetry, more commonly done for chiasmal and retrochiasmal dysfunction, glaucoma, and in chiasmal misrouting, especially in albinism. These are all the waves that need to be seen for all the three major types of VP that are done. That is all for VP. Thank you for listening.
Thank you, Dr. Nidhi. So now in this instruction course, there were 3 parts. Number 1, whom do you refer to for electrophysiology? What are the patients, what are the kind, what are the disease that you suspect? Number 1. And number 2, a technician. The technician has to be expert. What kind of investigation that you have ordered, he has to prepare the patient and put the electrodes accordingly. And number 3 is you have to read the result that comes out from the machine or a printout. And number 4 is what waves you have to see. Somewhere you have to see the wave A, somewhere you have to see the oscillations, somewhere you have to see the wave B, and somewhere you have to see N95 and P50 and P2 waves. So if there's any question from our audience, they can ask us.
I have a couple of questions. I think Dr. Vibhuti or Dr. Kashyap sir, any one of you can take it. In normal routine practice, we get a good number of patients of RP and those patients who are on ethambutol or an SCQ. So in case we find a patient with RP, should we subject all the siblings, or if the parents are is having RP, all the children to these kinds of tests just to screen, number 1. And number 2, in cases of, we see when the patients are on ethambutol or SCQ, when should we advise them, after how many months, or what is the time frame, when should we advise them to undergo these tests? So,
as drug toxicities go, so as far as drug toxicities go, the routine practice of monitoring in any drug toxicity is to monitor the patients every 4 to 6 weeks. You need not subject them to a pattern ERG. If the patient's vision is fine, the OCT signals are fine, but yes, once you are we may do the scan once initially and then once after the initial scan at 4 to 6 weeks, and then we can just follow it up with the routine complaint-wise follow-up, vision-wise follow-up, an OCT-wise follow-up, because see, the electrophysiology is a detailed examination at the end of the day. So if it is not feasible that way, we can always do an initial and a first follow-up and then carry on from there. But if we see a deterioration, we have to monitor it after cessation of the drug or the reduction of the drug. We have to then sequentially, we must do a pattern ERG, ideally, if it is there with you. Secondly, with respect to the siblings that are having carrier of the RP patients, the first go-to investigation always is a fundus examination and the routine OCT scans. But if, and of course, an FAF, autofluorescence, because all of these are non-invasive tests. Once we see any kind of suspicion, then they must be subjected to an ERG.
Yeah, I agree with you, because before the structural changes come, you get the functional changes much before ahead of time. So in case of the family history of retinitis pigmentosa, you do the ERG, fulfill ERG at the first instance that you can get it. It will tell you what is the prognostic value and what is going to happen to this baby. And drug toxicity, mind you, the multifocal ERG should be done along with the OCT also, because you get a lot of change in the OCT as well. And the area to see in the multifocal ERG is between the second and third ring. That is parafoveal area.
Thank you, sir.
So I think with this, if there is no question, audience, do you have any question? No? Thank you very much for this timely completing this session. To all the speakers, Dr. Vibhuti Kashyap, Vibhuti Lushan, Dr. Nidhi, Dr. Bharti, and Dr. Rahul, thank you very much.